Hello, hi. So now we are going to start our today's virtual workshop on basic life support. So first of all, I want to make sure, are you all able to hear me properly?
Yeah.
Uh, yep, fine. So my name is Lakshma and I am one of the A&E doctor who is working in NHS hospital emergency department. So I will basically cover a brief kind of introduction on basic life support and we'll cover a few points on advanced life support that will help clinicians while working in emergency or any of the department. Doesn't matter. So the subtitle is Essential Skills for Emergency Response. And so what is basic life support first? Can you, Mohammad Ali, can you please start the second slide if it is possible? Yeah. So first of all, basic life support is a kind of things we have to initiate to recognize any unresponsive patient and initiate an emergency response, and it contains a chain of survival. So the first step is always early recognition of any unresponsive patient or victim and activate the emergency response like call for help. And the second step is to start early cardiopulmonary resuscitation, and third is early defibrillation, and fourth is advanced life support, and fifth is post cardiac arrest care. So I will come on each and every point like a bit more. So first of all, when we see any unresponsive patient either in hospital or either in road anywhere like in the bus stop anywhere, so first step is always to recognize whether they are having a signs of life or not. And we can do that by like go close to the patient or victim, check for signs of survival or life, and we can check it by like putting our face close to the patient, checking if there is any air coming from their nose or mouth, and see the chest wall movements, either they are having any chest wall movements, and we can simultaneously check for the carotid pulse and do all together to save the time. And once we have seen like there is no pulse, no respiratory movement, no air coming out of the mouth, that means the patient is unresponsive, and you have to first take care of your surrounding, like maintain the personal safety and call the resuscitation team or ambulance, whatever emergency response available in your country. Like in UK, we dial 999 or 111 to activate the emergency response. And after activating that, just start the CPR. So CPR is basically contain the chest compressions and pulmonary, that is like giving the rescue breaths. So first of all, start the chest compression. How we can do that? So make a kind of fist or like hand over the hand and put on the lower sternum part of the chest of the patient or victim. And so, to give a high quality CPR, we have to make sure that we are pressing the chest like one third depth of the patient's chest, or we can say a few inches. Like we have to make like it is pressed one third of the chest, and then give the sufficient um, recoil of the heart, and you can do that by like pushing your hands back, like give the chest compression one third and then give the time for heart to recoil to give to have a flow of the blood. So this is a kind of CPR. So you have to give 30 chest compression, and after that you have to give 2 rescue breaths. So it's 30 ratio 2, 30 chest compression with 2 rescue breath, and do it for at least 2 minutes. Okay. um any point so far? If it is not clear, I can clarify at the end of our workshop. And the third point is early defibrillation. So I don't know, it's all depend on the area or the country or where we are living. So in most of the countries, they have fitted automated external defibrillation devices, like in the public access defibrillation, and that can be achieved quickly via public access. And defibrillation has a great role in survival rates. So if defibrillation is started within 3 to 5 minutes of collapse, it can produce survival rate as high as 50 to 70% chances, and it's a like huge amount. And this can easily be achieved by accessing the public defibrillation, even by a bystander or any to use any nearby AED to deliver the first shock, because each minute of delay to defibrillation reduce the probability of survival, and also reduce the chances of good outcome. So like in UK, an AED is deployed in about 5% out of hospital. So it all depend, like if we have access of early defibrillation, and otherwise, like if we are in hospital, so obviously we have got access to defibrillation. So while you are doing the chest compression CPR, ask one of the bystander or your colleague, whoever is nearby, to bring the AED or to bring the defibrillation. So put the defibrillation, it's all self-explanatory device. It will explain you where to attach the pads. Like there are two sides where we need to attach the pads. One is on the upper left side of the chest, right upper side of the chest, and the lower side of the chest, and that can analyze the rhythm. Don't stop CPR, you have to continue CPR, but while analyzing rhythm you have to pause the CPR, because otherwise it won't be able to analyze rhythm. So once it analyzes the rhythm, the machine will tell you whether it's a shockable rhythm or non-shockable rhythm. And if it is shockable rhythm, it will tell you, just like recharge the battery and place the shock. So you have to make sure that everyone is standing clear, but the one who is doing the CPR, he needs to continue the CPR. Once the battery is like, once we have pressed the charge button, we can tell that person, please go away, like clear the field, and then the press the button shock, and it will deliver the shock. Fine. So after delivery of shock, very quickly resume the CPR again and continue that CPR for 2 minutes again before analyzing another rhythm. So we have to do that CPR and defibrillation till we get our emergency response, like ambulance arrive, or the hospital staff, or the resuscitation team, or the medical team, whoever arrive. Till that we have to continue that CPR. Another, like if the patient has started signs of life, in that case also we need to stop the CPR. Fine. So once we have achieved the basic life support by giving the CPR, by giving the defibrillation, and once we have received hospital or the emergency or ambulance response, then it comes or falls into advanced life support thing. Mohammad Ali, can we switch to the next slide if it is possible? So, are you guys are clear about that, or if anyone have questions so far, like in this slide, the previous slide, I can explain a bit more. So, I assume everything is fine with that. Fine. So first step, we are gonna go a bit deeper. As I told earlier, like what are the signs of cardiac arrest or unresponsive? So we have to check are the patient is responsive or not, and we can do that by checking the patient. If we know their name, we can call by their name. If we not, then just shake and say, please tell me your name. Like just check if they're responsive or not, and if not, then check for their breathing and pulse, like and chest wall movement. So you can check the breathing by putting your face closer to the patient mouth, and on the same time you can also palpate the carotid pulse to check if there is any pulse. So these are basically the signs of life. So going to the another slide, can we? Yeah. Okay. So chest compression, as I already told you, that it's a hand placement. So put your both hands together at the center of chest at the lower third of the sternum. So compression depth is actually, I just compare with the patient's whole depth, and we have to compress like at least 1/3 of their chest, and which is normally 2 inches for adult. So the rate of compression is like 100 to 200 compression per minute. So don't forget 30:2. You have to continue 30:2. So the one cycle is complete in 2 minutes, which is 120 seconds. And in 120 seconds, we can do that 30 chest compression followed by 2 breaths, again 30 chest compression followed by 2 breaths. So we have to do that for at least 120 seconds. I think that's 2 minutes. And so rescue breath, I think that the protocol has been changed of following the COVID-19 when there was like pandemic going on. So we stopped giving the rescue breath. So if we are working in hospital, obviously we have got that bag and mask ventilation, we can give the breath through that. But if we are just like bystander, then obviously we need to give that by mouth to mouth rescue breath. So always ensure the airway is open, and that's always the first step when we recognize the patient is unresponsive. So to open the airway, there is a quick simple maneuver which is like head tilt and chin lift. So you have to tilt the head of the patient and lift the chin forward, and that will make like airway open when we are suspecting there is an airway compromise, so it can open the airway. And I think it's one of the quick maneuver to open the airway. Yeah, can we go on and next slide? Yeah. So automated. Are you guys are clear on the previous slide? Like, if any question you can ask right now, I can explain. If any questions or any queries. Okay, yes, clear. Fine. So using an automated external defibrillator. So importance of early defibrillation is I already explained that if we start defibrillation within 3 to 5 minutes of collapse, it can produce a dramatic survival rates as high as 50 to 70% chances of survival, and this can easily be achieved through public access defibrillation or in the hospital. So we are coming on the steps to use an AED. So it's self-explanatory device. There must be a turn on button, like a big green or red button. So turn on that, attach the pads to the patient bare chest. So if obviously if we are in hospital and the patient is like hairy, we can shave them, because we need to have a good pads attachment to the chest to give a maximum amount of shock. And if we are not able, then just attach the pad as much as we can to the patient's bare chest. And this is like on the upper right and the lower left. Follow the voice prompts. So it's a self-explanatory, and it produces the voice prompts like, okay, they're ready for analyzing the rhythm, and now it's a shockable rhythm, and now everyone is stand clear, and then deliver the shock. So it prompt the voice prompts, and it will tell you what you need to do. Ensure that no one is touching the patient before we deliver the shock, because it's electrical shock. So always maintain your own personal safety, and that's important. Is anyone clear on that AED? Can we jump on the next slide? Okay, so there are few special consideration. Children and infants, as we know, their anatomy, their physics, their length, their depth is completely different from adults. So their CPR is a little bit tricky. And so we can't give whole our force like chest compression, because we have to prevent any kind of cardiothoracic injuries in children and adults. So adjust your compression depth and rate. Use the pediatric pad, AED pad if available, but don't delay. If the patient is having a shockable rhythm, like a pediatric patient, and we don't have that pediatric pad, we can use the adult pad if if it is available. But the chest compression ratio is a bit different. If we are in hospital setting, then it's 15:2. But if it is same as bystander, then it's 30:2. And the choking, yeah, as I'm working in ED, I've seen a lot of kids coming with the choking, but most of them are like stabilized before they came to the emergency department. And this is the huge role of the public and the general population awareness on how to respond in a case of choking. So if they have like it swallow any foreign body and that has gone into their respiratory tract, so they have choking. There are few maneuvers and how to relieve that foreign body to come out of the mouth. And these are few maneuvers which in infant we use, like back blows and chest thrusts. Like you have to go give 5 back blows. I can switch on my video to show how it is normally done. So like if you are carrying infant, a baby, so hold them like their back, their head should be here, their back should be here, and it will be like in line with your arm holding them. And so give so first make them like on the back side, so their face and their tummy will be here. So you can give the 5 back blows and give it like in this way, um, back forward and upwards. That will help in taking out of the foreign body. And then the chest thrust as well. And the adult maneuvers a bit different. Like if they are choking, then and we have to stand behind them, hold them with our arms and make a fist and put like in front of their abdomen here and make fist like that, and give the thrust like in a forward and upward direction to relieve that, and give it like with whole pressure, tug 5 times, and to see, and always see after every thrust that if there is any foreign bodies coming out of their mouth. And this is a Hamlish maneuver which we use in adults. Is that whole clear? Okay, can we jump to the next slide? Fine. So there are special situations. Obviously, as unresponsive patient is not always like suddenly unresponsive, but there are always some risk factors or some trigger factor, like in drug overdose or ETH, like alcohol excess patient or trauma patient, drowning patient. So every patient has a special situation, but the basic life support is same. Like if you have got no signs of life, always start early CPR to prevent the cardiac arrest, because early recognition and call for help is necessary to prevent the arrest. Early CPR to buy the time, early defibrillation to restart the heart, and post resuscitation care. So unique consideration in these scenarios, I think it's a big topic and it needs a bit more time. So in drowning, we always start the CPR to take the extra fluid out of the lungs or airway tract, and they normally respond when this extra fluid came out. So you just start this chest compression, and the patient became back to life, and then no need to give the other things, like no need to give the rescue breath. But obviously if they are unresponsive, you have to give full CPR and rescue breath. Drug overdose, so it depends on which drugs they have taken. In most of the cases when we receive the patient and reassess, we don't know because patient is unresponsive. And if we find any friend or any bystander, we can take cultural history from them to find which drug they have taken, because most of the drugs have their antidotes to properly treat them. For example, if they came in with paracetamol overdose, we can give NIC, that is N-acetylcysteine, and if they have taken opioid, we can give naloxone. So once we find which drug they have taken, we can treat them as per tox base and their antidote. Okay, and coming to the trauma patient, they are a bit tricky and complicated patient, and it's not like the job any bystander can do. But as a clinician, we can at least stabilize the patient by doing their ABCD assessment. First, if they are unresponsive, again we have to start the CPR, but the CPR is quite tricky if they are having like ribs or cardiothoracic injuries, then their CPR is a specific kind, like not manual. It's like machinery CPR. It's depend on which hospital you are working. And again, if they are patient having pneumothorax or hemothorax, then we can put the needle to relieve that tension pneumothorax, or put the chest tube to relieve that pneumo or hemothorax. And so these are the special situations which normally covered in a hospital setting rather than the bystanding setting. So always just call for help and provide the best possible care you can. Fine. Can we jump to the next slide if we have? Yeah, it's a kind of like you always have to do regular updates and refresh your knowledge on BLS. Now, I would like to cover some ALS as well. I think that's important for clinicians to have a few, like, have a brief understanding on ALS advanced life support. So once we have like done the CPR and defibrillation and out of hospital setting or in hospital setting, now we can activate the adult advanced life support program, and that also covered the same thing, like unresponsive, not breathing normally, call the resuscitation team or ambulance team or activate the med call or the news call, start the CPR, attach the defib or the cardiac monitor, and then assess the rhythm. So in ALS, we come to a point of non-shockable and shockable rhythm. So there are always two rhythm in cardiac arrest: shockable and non-shockable. So shockable rhythms are two rhythms. One is like ventricular fibrillation, and that is life-threatening arrhythmia. Another is pulseless ventricular tachycardia. That is almost same as ventricular fibrillation. Only difference is it will be VFib is oral like wide QRS complex and with irregular. Feel like something is zigzag, and VTech is like wide broad complex ventricular tachycardia without any pulse, but we will treat both as same. So CPR for 2 minutes when the monitor has assessed rhythm, and it will tell you it's a shockable rhythm. Recharge the monitor, continue the CPR, all others stand clear, take the oxygen off, and ask the person who is doing the CPR to like clear the field. Everyone stand clear and then give the shock. After the shock, quickly resume the CPR and continue that CPR for another 2 minutes before assessing the rhythm. I always say, like, when you are assessing the rhythm, by the time. So, when the monitor is assessing rhythm, you can go and check the pulse and the respiration by auscultation to see if there is any signs of life. Because if we have a spontaneous return of circulation, we don't need to continue CPR. So always by the time when the monitor is assessing rhythm, go and check for pulse and auscultate patient for any respiratory movement. So again, CPR, another shock. If it is still shock at rhythm, we can give that shocks until the patient has got signs of revival. Always get IV access as soon as possible. Minimize the interruptions to compression, and the drugs which we give during cardiac arrest is adrenaline and amiodarone. So give the adrenaline every 3 to 5 minutes. It has very short half life, and also give the amiodarone, that is 300 milligram,
चल
and that is
वो
given after 3 shocks.
कौन चले जाओ
Okay,
बच्चा
sorry. Hi Almas, have you got any queries?
sorry sorry for the voice interruption sorry man
Okay, that's fine. That's fine. Don't apologize. Fine. So, and on the other side, if it is a non-shockable rhythm, which is like pulseless electrical activity, PEA, or asystole. So, how we recognize these rhythms on monitor? So, pulseless electrical activity is like normal ECG rhythm with no pulse, and asystole is a kind of flat line. So in that case, we don't need to give the shock. We just continue the CPR for 2 minutes and give the adrenaline as soon as soon as possible. Even if you are doing the CPR, don't wait to finish for 2 minutes. Give the adrenaline as soon as possible because it's an emergency drug for the heart. Anyway, so once there is a return of spontaneous circulation, give the oxygen, use the waveform capnography to check for carbon dioxide, identify and treat the reversible causes. So I always, when there is a return of spontaneous circulation, I always start with my ABCD approach, and we will show you in next few videos to clarify all these things. So first identify and treat the reversible cause. So there is a rule of 4Hs and 4Ts. 4Hs are like hypoxia. If there is any hypoxia, treat that with oxygen. Another H is hypovolemia. If there is low blood pressure and then there is sign of hypovolemia like delayed CRT, cold peripheries, cyanosis, so start the fluid boluses. And in cardiac arrest, we always give the boluses like 500 ml of normal saline or Hartmann solution, whatever we have got. So this will cover hypovolemia. And then the third H is kalemia, that is potassium. So always get one VBG when we are taking the bloods, like routine blood. Take the VBG to check for three things: pH, potassium level, and BM, because they are quite quick treatable causes. If there is hypoglycemia, we can treat with giving glucose. If there is a hypokalemia or a hyperkalemia, we can treat with potassium. If it is hyper, then again there is a whole guideline on hyperkalemia, salbutamol, insulin, and whatever drugs to decrease the amount of potassium in our body. And the fourth H is like hypo or hyperthermia. It's easily treatable. Like if they are hypothermic, we can put more blankets and we can start the heater. And if it is hypothermia, then we can cool them by air conditioner or giving the fluids. So this will cover 4 Hs. And then we come to the 4Ts point. 4Ts in 4T first is thrombosis, and that can be coronary or pulmonary thrombus. So coronary is like myocardial infarction, and that can be treated with monotherapy like aspirin, clopidogrel, whatever ACS treatment we have got, and or thrombolysis as well. And if it is PE, again we can start the thrombolysis to dissolve that clot. Another T is tension pneumothorax. So I think you all are aware of what tension pneumothorax is. Apologies, I was just drinking the water. So tension pneumothorax in cardiac arrest setting, we will not wait for the X-ray to come and have a look. We will continue our CPR. And there is a great role of bedside ultrasound. We can quickly do that ultrasound in I think 5 seconds or 10 seconds pause to check if there is any sign of tension pneumothorax, and that can be done by a person who has got some expertise in doing a bedside ultrasound. So if they detect the air, we can easily put the needle and get that air out. Another 4 is tamponade. So tamponade is like collection of fluid in a pericardial activity that compress your 4 chambers of heart. We get like backstride, I think hypovolemia, raised JVP, and muffled heart sounds. And that can also be treated by pericardiocentesis, like put a needle in pericardial activity and get that extra fluid out. So this is the third. And fourth T is toxins. So in most of the cases we get like toxic patients. We can always find with the collateral history or by checking the patient records whether they have been given overdose of paracetamol or any other medication, and treat that with their specific antidotes. So these are like identify and treat these reversible causes. And I would suggest like consider ultrasound imaging because it has a great role nowadays to identify the reversible cause. We can easily detect tamponade, we can easily detect tension pneumothorax, we can easily detect thrombosis like PE, in which we get get the right heart stain features on ultrasound. So these are the things we can see on bedside ultrasound. It's quite useful. Now, considering like there are a few mechanical chest compression to facilitate transparent treatment, like in a case of trauma patient, extracorporeal CPR, but it's again a kind of advanced support. So once we have got return of spontaneous circulation, start your ABCD approach. Airway, check for airways. If they are speaking now, that means their airways are intact. If not, then intubation and ventilation. B, check for breathing rate, their oxygen saturation. Give the high flow oxygen. M for oxygen saturation is 94 to 98 percentage, and normal PaCO2. C for circulation. Always get to a lead ECG to get like idea about their heart rhythm rate, and also give the fluids and check for blood pressure, pulse, CRT, and again identify and treat the reversible causes. And in D, we can check the BM, we can check the GCS, we can check the pupil response, and then E for is like whole from head to toe,